The presentation is physically exhausting and often alarming. A severe, persistent cough drives adults with acute respiratory infections to seek urgent medical attention. This is the clinical profile of acute bronchitis. It is defined by an acute onset, featuring a cough that typically persists for 1 to 3 weeks. The pathology is localized. Symptoms result from inflammation within the large airways, the bronchi. Because the distal alveoli remain clear and fluid-free, the condition is physiologically distinct from pneumonia. The epidemiological impact is significant. Acute bronchitis accounts for approximately 10% of all ambulatory care visits in the United States. This frequency highlights a sharp clinical discrepancy. Major medical societies recommend against routine empiric antibiotics because fewer than 10% of cases involve bacteria. Yet current data shows that between 50 and 90% of these patients receive an antibiotic prescription. This gap between evidence and practice makes acute bronchitis a primary driver of inappropriate antibiotic overuse on a global scale. Overuse stems from clinician anxiety regarding undiagnosed pneumonia, supported by the inaccurate concept of acute bacterial bronchitis in otherwise healthy patients. Breaking this cycle requires clinicians to discard the bacterial myth and rely on objective physiological thresholds for diagnostic testing. Seasonal respiratory viruses cause the vast majority of acute bronchitis cases in healthy adults. Surveillance data shows a clear correlation. Acute bronchitis maps directly to the pronounced winter peaks of rhinoviruses, enteroviruses, and influenza. Even outside the winter surge, common coronaviruses and parainfluenza maintain a steady baseline, ensuring a constant presence of viral infections year-round. Despite this evidence, clinical instincts often favor a bacterial explanation. However, in patients with normal airways, acute bacterial bronchitis is a concept without clinical support. Pathogens like Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis do not cause acute bronchitis in immunocompetent adults with intact mucosal barriers. These bacteria only become relevant if the patient has structural lung disease, COPD, or an artificial airway like a tracheostomy. A common clinical distraction used to justify antibiotics is the presence of purulent sputum. Yellow or green sputum is simply a marker of inflammatory peroxidase and Slough cells. It has no predictive value for bacterial infection and does not indicate a need for antibiotics. Assumptions based on sputum color or common respiratory pathogens lead directly to a massive cascade of inappropriate empiric prescribing. Diagnosing acute bronchitis requires the rigorous, safe exclusion of pneumonia. For a patient without COPD, the clinical pathway is streamlined. Chest radiographs and diagnostic tests are unnecessary unless the patient meets specific clinical triggers. This algorithm establishes the specific physiological gates required to justify imaging for parenchymal consolidation. These gates are defined by absolute vital sign thresholds: a heart rate exceeding 100, a respiratory rate over 22, a temperature above 38 degrees Celsius, or oxygen saturation below 95.
When these vital sign abnormalities and exam findings are absent, the clinician can confidently confirm acute bronchitis through history and physical examination alone. At this stage, sputum cultures and procalcitonin testing provide no clinical utility and are not recommended. Strictly gating tests behind these objective triggers protects the patient from radiation and prevents the clinician from initiating a cascade of unnecessary investigation. Effective triage requires identifying the rare fraction of cases where specific intervention is actually indicated. This list of pathogens defines the boundaries for testing. It is reserved for cases where results shift outpatient management or infection control. Testing for influenza or SARS-CoV-2 is indicated only if the patient's risk profile makes them a candidate for early antiviral treatment. Bordetella pertussis is the most likely bacterial cause of a subacute cough responding to antibiotic therapy. The diagnostic pathway for pertussis testing requires specific phenotypic markers. Clinicians should look for severe paroxysmal coughing, a distinct inspiratory whoop, or post-tussive emesis. Without these symptoms or a known exposure, hunting for atypical bacteria like mycoplasma is an inefficient use of clinical resources that does not change the recovery course. Targeted evidence-based testing based on rigid symptom profiles must permanently replace the outdated habit of blanket empiric prescribing. Antibiotics are often viewed as a harmless safety net for persistent coughs. Clinical evidence suggests otherwise. Large-scale meta-analyses show that amoxicillin and macrolides do not reduce cough severity, shorten the illness, or prevent complications in patients with acute bronchitis. To understand the risk, we have to look at the statistical reality of the number needed to harm. For acute bronchitis, the number needed to harm is 24. For every 24 patients prescribed an antibiotic, one will suffer a direct adverse event, ranging from nausea and diarrhea to C. difficile infection or anaphylaxis. Beyond side effects, these drugs disrupt the patient's microbiome. This alteration can impair the body's natural immune defenses while simultaneously promoting resistant organisms within the community. In this clinical context, empiric antibiotics provide no proven reward while introducing measurable and sometimes severe physiological risk. Management of acute bronchitis centers on education and resetting the patient's timeline for recovery. Clinicians should explicitly state that the cough is expected to persist for an average of 18 days. Establishing this duration early prevents patient frustration when symptoms do not resolve in a week. For symptom relief, recommend non-pharmacologic options like hot tea, honey, and throat lozenges. Over-the-counter dextromethorphan or guaifenesin can be offered if the patient requests medication. There are clear boundaries for treatment. Avoid opioid cough suppressants like codeine due to their side effect profile, and avoid oral corticosteroids, which have shown no benefit in randomized trials. Inhaled beta-agonists like albuterol should be strictly reserved for patients with active wheezing or known underlying airway disease. For patients who desire medication, the delayed prescription strategy is an effective behavioral tool. Providing a script to be filled only if symptoms worsen after a set period can significantly reduce unnecessary antibiotic use. Confidently navigating shared decision-making and symptom management allows the clinician to provide effective care while strictly adhering to the principle of doing no harm.